involves a periotomy with the scalpel and the extraction of 1.1 and the removal of circumferential epithelial tissue. The movement to extract is circumferential, no vestibular palatal, and then with the scalpel we create a partial thickness envelope with a vestibular incision with the scalpel blade 15C. With a small periosteum elevator type molt, we can perceive the bone walls apical to the defect and mesial and distal in a manner to isolate the bone defect to then facilitate the insertion of a collagen membrane. So we also collect the palate area always with the scalpel and periosteal elevator. Okay. Now let's go and check with after this phase with the periodontal probe, and we check the extension of the vestibular envelope created by filling the surrounding bone planes. And we go on the vestibular, we go on the palatal area. At the end of this point, we go to the palate, and with a circular mucotum type scalpel of 8 mm of diameter, we go to carry out a circular punch of connective epithelium in the area of the second premolar, first molar. So we took epithelial connective tissue graft. And now we sink the scalpel for about 34 millimeters without touching the bone plane under. And so underline. And then with the surgical forceps and the standard scalpel, we take the palatal punch. We remove the punch. Once the sampling has been carried out to obtain hemostasis of the site, we place oxidized cellulosa, blocked with cross stitches and suspended from the teeth. So this is the moment of the suture. We go in direction distomesial direction, and to block we obtain the hemostasis quickly. And hemostasis is almost immediate after this, and this is the palata. So when we finish this area, we go to work with the palata punch. Okay, after this, I think we have finished, and we have done cross stitches and suspended from the teeth, and so we have obtained the correct hemostasis of the palate immediately. So this is the palatal punch, and now we start the second phase of our surgery with ridge augmentation. So we are going to prepare the collagenated bovine bone graft to be inserted into the extraction seat, which must be hydrated with sterile physiologic solution. And now we shaped outside the mouth a membrane in pork collagen, which must insert into the vestibular envelope and rest on the apical, mesial, and distal bone planes of the bone defect. So the modeling must be carried out with the membrane dry out of the mouth in sterile situation. And once the desired shape has been obtained, we insert the membrane vestibulary with the help of a surgical tweezer and a periosteal elevator, working both vestibulary and from inside the alveolus to make it adhere to the vestibular bone planes. It's essential to obtain a correct positioning, since it must work as a barrier vestibular wall, a new vestibular wall. So yeah, we have to be sure that we are on the bone. on the bone plate. So once the vestibular portion has been positioned, we insert the collagenated bovine bone graft material and pick the alveolus. And then after this, the collagen membrane is then tilted palatally and inserted under the palatal flap above the palatal bone crest. Okay, like this. So after this point, we have finished the ridge augmentation phase, and we must move on the second seal phase. Now we start to suture the punch with a 5060 absorbable suture, and we position the graft after having desepithelized the margins with a scalpel and 15C, and now starting to suture the ends of the punch with detached stitches. We start from the mesial vestibular angle, entering the graft and exiting the flap, and once blocked with a little care, we go to suturing the opposite end of distopalatal. First of all, so mesio-vestibular and then distopalatal. So the graft is blocked in this position after the first two sutures. And then we can go to suture the other extremities, the other corners. So disto-vestibular, and after this, always from the graft to the flap, and the last one is mesiopalatal. It's important to use suture very little, 50, 60, sometimes 70, reabsorbable. Now, usually we use acid polyglycolic suture. After this, we can perform a final suture to crush the vestibular flap in the palatal direction and against the graft by performing an external horizontal crossed mattress. We can do the first one, and after this the second one. We enter on the vestibulary, and then after this we go on the palatal, and when we hand the suture, we have the moving. We move the flap against the punch. We can do the first one and the other one on the distal aspect to block the graft. It's important that this graft is very easy mobilized, because if it's not easy, we can have some necrosis of the graft. After this is the end of the first surgery, and 4 months later, this is the clinical situation. We have increased volumes and quality of soft tissue with a new presence of keratinized tissue in weight and thickness, and we have not lost the verticality of the tissue. Actually, we have definitely increasing. After taking digital impression with optical scanner, and we can go then to organize the guided surgeries with new horizontal GBR plus increase of soft tissue with connective tissue graft. The programming of the guided surgery with dedicated software is allowed to program the position of a conical volution implant with internal connection, diameter 3.75 and length of 11.5 millimeter. Analyzing the seat in detail, we can see that shoulder forward increase the vestibular bone volume to reach the ideal thickness of vestibular bone, and also we can increase the soft tissue with the connective tissue graft to arrive at the ideal thickness. So this is the second video. We make a full thickness incision with a scalpel and 15C blade, is slightly vestibular paracrestal extender from 1.2 to 2.1. And with the dissector, we begin to collect the access flap. And we continue the disconnection with the periosteum elevator type MOLT until we reach the bone crest vestibulary and also in palatal area. So the good bone regeneration is heightened, a situation completely different from the initial situation before the first surgery. We can see the new bone crest with also the bone graft is still matured. And so next I tried the dental supporter surgical guide, checking it perfectly fit and precision, and being careful to let the vestibular flap step outside the guide. So we start the passage of the drills as the surgical protocol of the chosen implant system. And the drills will go in sequence from the 2.2 millimeter diameter up to the 3 millimeter drill with a length of 11.5 millimeter to prepare the socket for the chosen implant. The chosen implant is 3.75 for diameter for 11.5 millimeter of length. In this phase, it's always fundamental abundant irrigation with cold sterile physiologic solution at 4 degrees centigrade to avoid overheating of the bone. And we must always pay very care in dental support guides. Therefore, without fixing pins, keep the guide well locked with the fingers of the other hand, and during the pass of the drill, and during the position of the implant to avoid inaccuracy during the surgical phase. We are now ready to take the implant from its sterile blister with the carrier. The implant chosen is, we know, and evolution implant with a 1.5 millimeter machined neck with integrated platform switching and a tapered body with a double thread well aggressive on the bone tissue. A versatile implant in every clinical situation, which always allows you to find an excellent primary stabilization. Once the torque with a physiodispenser of 45 newtons per centimeter is reached, you switch to the torque wrench until the system is correctly dropped with a final torque of over 60 newtons on centimeter. At this point, we must take a periosteal incision to free the vestibular flap, to make it slide in the coronal direction and cover the horizontal GBR that will make and the connective tissue graft that will place under the flap. So now we can see the right position of the crest of the bone. And so we can do an incision that is made with a scalpel and a new 15C blade, okay, in the bottom of the flap. Okay, first of all, we can check the connective tissue graft that we had taken from the palate area. Okay, we have done from palate area connective tissue graft, and now after this we can do the incision made with the scalpel and new 15C in the bottom of the flap in mesiodistal direction, separating the periosteum from the overlying flap until it's completely relaxed. We have to pay attention not to cut the flap. And now, after this, a pork collagen membrane appropriately shaped outside the mouth in a sterile environment is inserted and blocked under the palatal flap in the bone, above the bone crest, and an autologous bone graft taken from the drills during the implant preparation is performed with mixed with deproteinized bovine bone and positioned vestibulary to the head of the implant to perform a horizontal GBR, which will allow me to have a vestibular bone thickness for my implant at the end of the last 2 mm like described in the literature. After the membrane is then tipped onto the vestibular, and once wet with blood, it adheres well to the surrounding bone plates, and it's positioned well on the vestibular and palatal. And now we are ready to position the connective tissue graft, which is inserted and blocked coronally on the vestibular flap, so to increase the thickness of and height of keratinized tissue. The graft is blocked with a 260 absorbable polyglycolic acid sutures on external horizontal mattress. And so at this point, the suture between the vestibular and palatal flap is completed with a 4-0 single suture in pseudo-monofilamento. And the closure of the flap is without tension because we are relaxing the flap with the periosteal incision. So we can do the single suture from the mesial aspect to the distal aspect to close the space and the flap. This is the end of the surgery, or the video of the surgery. And so this is the clinical situation 5 months after implant surgery, when we go to discover the implant. We have reconstructed the soft tissue with keratinized gingiva correct in height and thickness, and we also radiographically reconstructed a correct profile of the bone tissue. We take a digital impression with an optical scanner to create a temporary screwed onto implant, which, based on a drawing, a correct subgingival morphology will guide the maturation of the soft tissue. After 2 months of tissue conditioning, this is an excellent result obtained, and now we simply, with the digital scanning protocol for finalization, will create the final screw-retained zirconia crown in a layered ceramic.